Your body has been trying to tell you something. Not loudly, not dramatically, not with a single unmistakable signal you could not miss, but consistently across multiple systems in ways that are easy to explain away as something else entirely. A fatigue that sleep does not fix, a mood that has flattened without obvious reason, a heartbeat that occasionally feels off, skin that looks pale despite reasonable health. These are not isolated complaints. In a significant number of cases, they are a coordinated distress signal from a body that is running critically short on one of the most essential vitamins in human biology. Vitamin B12 is not a supplementary nutrient, it is a foundational one. Every single cell in your body depends on it. Your red blood cells cannot form properly without it. Your nervous system cannot maintain its insulation without it. Your DNA cannot replicate accurately without it. Your energy metabolism cannot function at full capacity without it. And the reason a deficiency can go undetected for so long is that the body is extraordinarily good at compensating, borrowing from reserves, redistributing resources, maintaining surface level function long after the underlying system has begun to deteriorate. By the time someone in the emergency department presents with a condition I can clearly trace to B12 deficiency, they have almost always been symptomatic for far longer than they realized. They have been attributing the signs to other things, to their age, their stress levels, their diet, their sleep, and in many cases, those explanations were not completely wrong. They were just incomplete. What was missing was a B12 level nobody had thought to check. What I want to do in this video is change that, because the 8 warning signs I am going to walk you through are specific. They are biologically grounded. And most importantly, they are recognizable early, at a point where correction is straightforward, full recovery is realistic, and long-term damage can still be prevented. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly a decade on the front line of the AAND, I have seen what happens when preventable deficiencies go uncorrected until they cannot be ignored any longer. I have seen people come in convinced they were having a stroke, whose symptoms resolved when we corrected a B12 deficiency that had been silently progressing for years. I have seen profound fatigue, the kind that had taken people out of work, out of social life, and very nearly out of hope, that turned out to have a correctable nutritional driver nobody had investigated. And my purpose in building this channel is to help people understand these connections before they are sitting in my department. Before I go through the 8 warning signs, I need to spend a few minutes on how B12 actually works inside your body. Not in abstract terms, but mechanistically, because the signs only make sense when you understand the biological role B12 is playing in each affected system. That is the foundation that turns a list of symptoms into a coherent picture. I promise to keep creating the most helpful videos I possibly can, grounded in the science and the latest research, designed to help you live longer and avoid the diseases I encounter every day in emergency medicine. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely new, then feel free to unsubscribe. No hard feelings at all. But if you give me your time and your attention, I will give you everything I have learned from over a decade in medicine. Please hit that subscribe button and let us get into it. Vitamin B12 is what biochemists call a coenzyme, meaning it does not act independently inside your body, but instead enables other chemical reactions to take place. Without it, several critical biological processes simply cannot proceed, and those processes touch nearly every system in your body. The first and most important role is in red blood cell production. Inside your bone marrow, stem cells are constantly dividing to produce new red blood cells, approximately 2 million new cells every second. That cell division requires DNA replication, and DNA replication requires folate, which in turn requires B12 to be properly activated and recycled. When B12 is insufficient, this folate recycling stalls, DNA synthesis slows. Red blood cell precursors keep growing without dividing properly, producing what are called megaloblasts, oversized, structurally abnormal cells that cannot carry oxygen effectively. The resultant condition, megaloblastic anemia, reduces your blood's oxygen carrying capacity systemically. Every tissue in your body receives less oxygen than it needs, and that single downstream effect produces a cluster of symptoms that touch energy, cognition, skin, heart rate, and mood all at once. The second role is in myelin synthesis. Myelin is the fatty insulation that coats your nerve fibers, allowing electrical signals to travel fast and accurately from your brain and spinal cord to every muscle and organ in your body. B12 is an essential cofactor in the methylation reactions that build and maintain myelin. When B12 falls, myelin degrades faster than it is replaced. Nerve signals slow, misfire, or fail to arrive. The peripheral nerves, the long fibers running to your hands and feet, are affected first because they have the most myelin to maintain over the greatest distance. But the process does not stop there. Over time, in more severe or more prolonged deficiency, it moves centrally into the spinal cord, the optic nerves, and the brain. The third role, and one that is often overlooked, is in homocysteine metabolism. Homocysteine is an amino acid that your body produces naturally as part of protein breakdown. Under normal conditions, B12 and folate work together to convert homocysteine back into a harmless compound called methionine. When B12 is insufficient, this conversion stalls and homocysteine accumulates in the blood. Elevated homocysteine is not simply a marker of deficiency, it is itself actively damaging. Research published in the journal Circulation has shown that elevated homocysteine damages the inner lining of blood vessels, promotes arterial stiffening, and is independently associated with increased risk of cardiovascular events and cognitive decline. This is the mechanism that makes prolonged B12 deficiency a genuine cardiovascular and neurological risk, not just a nutritional inconvenience. The fourth element of the foundation is absorption, and this is where the real deception lies. B12 is unique among vitamins in requiring a specific carrier protein called intrinsic factor, produced by specialized cells called parietal cells in the stomach lining, to be absorbed through the gut. Dietary B12 binds to intrinsic factor in the small intestine and is then transported across the gut wall into the bloodstream. Without adequate intrinsic factor, dietary B12 passes through your system essentially unused, regardless of how much B12 you are eating. Intrinsic factor production declines naturally with age. It is suppressed by proton pump inhibitors, one of the most commonly prescribed drug classes in the developed world. Metformin, widely used in type 2 diabetes management, interferes with B12 absorption through a separate but equally significant mechanism. And in a condition called pernicious anemia, the immune system attacks and destroys the parietal cells entirely, shutting down intrinsic factor production permanently. What this means is that B12 deficiency is frequently not a dietary problem at all. The food contains adequate B12, the body simply cannot extract it, and that distinction matters enormously for how the deficiency needs to be treated. That is the biological framework. Now let us look at what that framework predicts and what you might recognize in your own body as a result. Just really quickly, if you are finding this useful so far, please consider subscribing. It helps this channel reach more people who genuinely need this information. Here is the pattern I see repeatedly, and it is one of the most frustrating aspects of this deficiency from a clinical perspective. People come in having had blood tests done, sometimes multiple rounds, and they have been told everything is normal. And in a strict technical sense, that may be true by the thresholds printed on the lab report. But those thresholds are based on population distribution, not on the level required to prevent progressive tissue damage. Research published in the New England Journal of Medicine has established that metabolic markers of B12 insufficiency, specifically elevated methylmalonic acid and elevated homocysteine, frequently appear in people whose serum B12 sits in the low normal range. The lab says normal, the body says otherwise. That gap between what a test reports and what is actually happening biologically is where these 8 warning signs live, and they matter precisely because they are detectable before the damage becomes irreversible. The first warning sign is extreme fatigue that does not respond to rest, not ordinary tiredness. Everyone experiences that. This is a fatigue that persists after a full night of sleep, that makes normal daily activities feel disproportionately effortful, and that does not improve meaningfully with rest or relaxation. The mechanism is directly tied to red blood cell dysfunction. When megaloblastic anemia reduces your blood's oxygen carrying capacity, your tissues are running on a reduced energy supply regardless of what you eat or how much you sleep. Simultaneously, B12 deficiency impairs mitochondrial function at the cellular level, reducing ATP production, the actual energy currency your cells run on. You end up with an energy deficit operating at two levels at once: insufficient oxygen delivery from above and impaired cellular energy production from below. I have had patients come through the department describing fatigue so profound they had stopped socializing, stopped exercise, and in some cases had taken long-term sick leave, whose energy returned substantially within 6 to 8 weeks of B12 correction. That is not a coincidence. That is a mechanism resolving. The second warning sign is pale or slightly yellow-tinged skin. Pallor is the classic visible sign of anemia, when red blood cells are reduced in number or abnormal in function, and the skin loses the pink undertone that comes from hemoglobin beneath the surface. But B12 deficiency adds a second visible effect that is more specific: a mild jaundice or yellowing, particularly noticeable in the whites of the eyes. This happens because the abnormal red blood cells produced during megaloblastic anemia are fragile and break down faster than normal red blood cells. That breakdown releases bilirubin, a yellow pigment, faster than the liver can process it, and a mild yellow tinge accumulates in the skin and sclera. It is subtle, easy to miss, and frequently attributed to other causes. But in the presence of other warning signs, it is a meaningful clinical indicator that points specifically toward B12 and folate metabolism. The third warning sign is heart palpitations, a sensation that the heart is beating faster, harder, or more irregularly than usual without obvious exertion or anxiety as the cause. When anemia reduces the oxygen carrying capacity of the blood, the heart responds by increasing its output to compensate, beating faster and more forcefully to circulate more blood volume per minute. This is not a cardiac problem, it is a compensatory response to an oxygen transport problem. The heart is working harder because the blood it is pumping is less efficient at delivering oxygen than it should be. Most people experiencing this will have a normal ECG, normal cardiac enzyme levels, and a cardiologist who finds nothing structurally wrong because nothing structurally is wrong. The driver is hematological, not cardiac, and correcting the B12 deficiency is what resolves it. The fourth warning sign is shortness of breath on mild exertion, climbing a flight of stairs, walking briskly for 5 minutes, carrying shopping bags from the car. Activities that should present no meaningful challenge begin to feel breathless. Again, the mechanism is anemia and reduced oxygen carrying capacity. But the shortness of breath occurs because physical activity increases the oxygen demand of working muscles, and a system already operating at reduced oxygen delivery capacity cannot meet that increased demand comfortably. The lungs are working fine, the heart is working harder to compensate, but the fundamental bottleneck is in the blood itself. Like the palpitations, this symptom points people toward cardiac and respiratory investigations that come back negative, while the actual cause remains undetected because nobody checked the B12. The fifth warning sign is mood changes, particularly depression, irritability, and emotional flatness. B12 is an essential cofactor in the synthesis of neurotransmitters, including serotonin, dopamine, and noradrenaline. These are the chemicals that regulate mood, motivation, emotional responsiveness, and the experience of pleasure. When B12 is insufficient, the methylation reactions required for neurotransmitter production slow down. What emerges is not always what people recognize as classic depression. It often presents more as a blunting, a reduction in emotional range, a shortened fuse, an absence of enjoyment in activities that used to bring satisfaction. Research published in the Journal of Affective Disorders has identified B12 insufficiency as an independent contributor to depressive symptoms, particularly in older adults. The crucial point is that antidepressants act downstream of the problem. Correcting the B12 addresses the upstream mechanism. Not your fault if this connection was never made. The standard depression workup in most clinical settings does not routinely include B12, but it arguably should. The sixth warning sign is mouth ulcers, a sore or inflamed tongue, or a persistent burning sensation in the mouth. These are grouped together because they share a common driver. B12 is essential for the rapid cell turnover that maintains all mucous membranes, including the lining of the mouth and tongue. When B12 is low, that renewal process slows. The tongue may become smooth and glossy as its surface structures atrophy, what clinicians call glossitis. Painful ulcers appear at the corners of the mouth or on the inner cheeks. A burning or tender sensation develops without any visible infection or injury. These are not dental problems or immune problems in isolation. They are surface-level markers of a systemic deficiency, visible to anyone who looks and frequently attributed to stress, acidic foods, or bad luck, rather than investigated nutritionally. The seventh warning sign is difficulty concentrating, word-finding problems, or what most people describe as brain fog. Not memory failure in the classic sense, more a slowing of mental processing, a difficulty sustaining focus, a frustrating gap between knowing what you want to say and being able to access the word quickly. The mechanism here operates through two pathways. First, reduced cerebral oxygen delivery from anemia slows cognitive processing across the board. The brain, as an organ with extremely high oxygen demand, is among the first to feel the effects of reduced oxygen carrying capacity. Second, myelin degradation in cognitive nerve pathways begins to slow signal transmission within the brain itself. Research published in Neurology has demonstrated measurable reductions in brain processing speed in people with low normal B12 levels, independent of other cognitive risk factors. In older adults, this symptom pattern is frequently and incorrectly attributed to normal aging or early dementia. The difference matters enormously because one is progressive and irreversible and the other is correctable. The eighth warning sign is pins and needles, numbness or a crawling sensation in the hands or feet that has no obvious mechanical explanation. Not the temporary numbness from sitting with crossed legs or sleeping on an arm that resolves within seconds of changing position. This is a persistent, recurring, often bilateral sensation that comes and goes regardless of position, often worse at rest or at night. The mechanism is early peripheral nerve demyelination, the myelin coating around the sensory nerves in the extremities beginning to degrade, producing misfired signals that the brain interprets as sensation where there is none. This is the earliest neurological sign of B12 deficiency in most people, appearing before any visible change on nerve conduction studies and well before the more severe manifestations of balance loss or limb weakness. It is also, in my clinical experience, the most frequently dismissed because it is intermittent, because it sounds vague, and because there are many possible causes. But bilateral persistent tingling in the hands and feet, in the presence of other signs on this list, is a specific enough pattern that it warrants immediate investigation. Before I go through the practical steps here, let me be very clear about one thing. I am not suggesting anyone alter their medication or manage this in isolation. B12 deficiency has multiple potential causes, several of which require medical investigation and monitoring. The goal of what follows is to help you understand what to ask for, what to expect, and how to approach correction intelligently, always in partnership with your doctor, not instead of one. The first and most important step is getting the right investigation and understanding what a normal result actually means. A standard serum B12 test is a reasonable starting point, but it has a well-documented limitation. It measures total circulating B12, not the amount that is functionally active at the cellular level. Research published in the American Journal of Clinical Nutrition has established that up to a third of people with serum B12 in the low normal range show elevated metabolic markers indicating true functional deficiency. So if your serum B12 comes back between 150 and 400 picograms per milliliter, and you have any of the warning signs I have described, I would encourage you to ask for two additional markers, methylmalonic acid and homocysteine. Methylmalonic acid rises specifically when B12 is functionally insufficient at the mitochondrial level. Homocysteine rises when the B12-dependent methylation cycle stalls. Together, these three markers give a far more accurate picture of your actual B12 status than serum B12 alone. This is a conversation worth having with your GP. The second step is identifying the cause, and this is not optional. A deficiency driven by inadequate dietary intake is corrected differently from one driven by impaired absorption. If you eat a fully plant-based diet and have never supplemented B12, dietary insufficiency is the most probable explanation and oral supplementation is the primary solution. High-dose oral B12, typically 1000 micrograms daily, can actually be absorbed in meaningful amounts even without adequate intrinsic factor through passive diffusion, where a small fraction of ingested B12 crosses the gut lining without the carrier protein. But if your deficiency is driven by reduced intrinsic factor production, whether from age-related gastric atrophy, from pernicious anemia, or from long-term use of proton pump inhibitors or metformin, oral supplementation will be inadequate regardless of the dose. In those cases, intramuscular B12 injections bypass the gut entirely and deliver the vitamin directly into the circulation. Your doctor needs to determine which category applies to you before treatment is selected. The third step involves understanding the timeline of recovery, because this is where realistic expectations matter. Some symptoms respond quickly. The fatigue, the palpitations, the shortness of breath on exertion, these reflect an anemia and improved oxygen delivery. And many people notice meaningful change within 4 to 8 weeks of beginning correction. The neurological symptoms, the tingling, the cognitive fog, the mood changes take longer, often 3 to 6 months for significant improvement, and sometimes longer still. The general principle from the clinical literature is this: the sooner correction begins after symptoms appear, the more complete the recovery. Symptoms that have been present for weeks to months are in most cases fully reversible. Symptoms that have been present for years may improve substantially, but not completely. That is the honest answer, and it is one of the clearest arguments for taking these warning signs seriously rather than waiting for certainty before acting. The fourth step is dietary optimization as a supporting layer, not a substitute for supplementation in cases of significant deficiency, but a meaningful contribution to maintaining adequate levels once correction is underway. The richest dietary sources of B12 are animal products. Liver and kidney carry the highest concentrations of any food, followed by clams, beef, salmon, trout, eggs, and dairy. For people who are absorbing normally, regular consumption of these foods is a legitimate long-term maintenance strategy. For people following plant-based diets, fortified foods, certain plant milks, fortified breakfast cereals, and nutritional yeast provide some B12, but the amounts are often insufficient to correct a meaningful deficiency without supplementation alongside. The key question is always absorption. A diet rich in B12 is only useful if the gut can extract it. The fifth step is monitoring. One test and one intervention is not sufficient if neurological symptoms are present. At 3 to 6 months after beginning correction, I would recommend retesting serum B12, methylmalonic acid, and homocysteine to confirm that levels are normalizing. If injections or high-dose oral supplementation are in use, your doctor will guide the frequency of retesting. What matters most is that improvement is tracked both through blood markers and through your own symptom experience, and that treatment is adjusted if the expected response is not materializing. B12 correction is not a one-off intervention. In cases where the underlying cause is persistent, pernicious anemia, ongoing PPI use, age-related gastric atrophy, ongoing supplementation or injection therapy is a long-term commitment, not a short course. In emergency medicine, the cases that stay with you are not the dramatic ones. They are the ones where the answer was simple, available, and entirely missed. Not through negligence, but through a gap in the standard framework. A woman in her early 60s coming in with profound fatigue, low mood, and tingling in both hands, who has been managed for depression for 2 years with partial response. A man in his mid-70s with a 6-month history of deteriorating balance, written off as age-related until someone finally checks a B12 level that comes back critically low. A person in their 50s on long-term metformin for type 2 diabetes, who has never been warned that this medication depletes B12, and who has developed early signs of peripheral neuropathy that could have been prevented entirely. These are not rare cases. Research published in the British Medical Journal has estimated that B12 deficiency affects up to 15% of people over 60, the majority of whom are undiagnosed. Among those taking proton pump inhibitors for more than 2 years, the prevalence is significantly higher. Among long-term metformin users, studies suggest depletion may affect up to 30% of patients when sensitive markers are used. We are not talking about a niche problem. We are talking about a common deficiency with a straightforward correction being missed at scale. What I have seen repeatedly in clinical practice is that the patients who recover most fully are the ones who recognize the pattern early and ask the right question, not the ones who waited until the fatigue was disabling or the tingling had become weakness. The ones who noticed several things changing at once: the energy, the mood, the skin, the sensation, and connected them rather than explaining each away in isolation. That connection is what this video is designed to give you. The 8 warning signs I have walked you through today are not incidental. They are biologically coherent. Each one is a direct downstream consequence of B12 insufficiency in a specific physiological system. The fatigue and pallor from failing red blood cells. The palpitations and breathlessness from the heart compensating for reduced oxygen delivery. The mood changes from stalled neurotransmitter synthesis. The mouth sores and tongue changes from impaired mucous membrane renewal. The brain fog from reduced cerebral oxygen and early myelin degradation. The tingling from peripheral nerve demyelination beginning its quiet work. Your body does not produce these signs arbitrarily. It produces them because something in its internal system is failing to get what it needs. And unlike many of the conditions I encounter on the front line, the ones with complex management, irreversible pathology, and narrowing treatment windows, B12 deficiency, when caught early, is one of the more correctable things a doctor can address. A blood test, an honest conversation, an appropriate treatment, and in many cases, a meaningful return to energy, clarity, and function that the person had stopped expecting was possible. That window is worth taking seriously. The earlier you recognize these signs, the more completely your body can correct what has gone wrong. If you found this useful, please subscribe to the channel to help me reach more people like you.